I'd just like to talk a bit about what goes on with regards to helping couples to achieve a family. Most of us assume that when we want to have a family, we'll start and we'll get what we want. Unfortunately, that's not the case for about 1 in 7 couples. And they may find themselves sadly screaming and ending up in my fertility clinic. Now, we're a fairly friendly bunch, but people don't actually want to be there. They want to be in the antenatal clinic instead. So following lots of extensive tests, the majority of couples will manage to conceive with simple medication, possibly ovulation induction, maybe even minimal access surgery to overcome their problems, and they'll get into the antenatal clinic. But for a smaller proportion, they need something far more complex called assisted conception. I'm going to give you a very brief overview of assisted conception and its history. Basically, assisted conception is where we take either eggs or sperm out of the human body. We do something with it, possibly in a laboratory, maybe even make some embryos, and we put it back into the patient. Now, most people consider IVF, and so IVF is quite sexy, and we'll talk quite a lot about IVF tonight, but it's also important to remember something called intrauterine insemination, which is a very valuable tool whereby we take the man's sperm, we put it through various preparations and we put it into the uterus, and a lot of women can get pregnant without having to take all the complex drugs associated with IVF. Louise Brown was the first IVF baby born in the whole wide world, and she was born on the 25th of July 1978, so that's only 34 years ago, so it's a relatively new speciality. So what really happens to these patients who need that kind of treatment? Well, the first thing to say is we have quite major legal obligations for those patients. We have to look into the welfare of the unborn child. Now, not many of us have to fill in forms to say that we haven't committed some serious crime or have congenital defects or some inheritable disease before we decide to have a family. But this is a legal obligation that all patients going through IVF have to do. Funding is a big issue, and in this current economic climate, there's never going to be quite enough money to go around. I'd like to treat everybody who needs it. Sadly, we have to do what our PCTs and local commissioning groups tell us to, and so there's not quite enough money to go around. But we do the best we can with what money we have. Our care is very patient-orientated. I've never seen 2 women or 2 men who are exactly the same. We're a small team of 3 consultants. Dr. Sheriff is here tonight, wave at us, Liz, and myself and Liz Ding. And what we do is produce a very individualised protocol depending on that lady's body mass, her hormone levels, her uterus, and what her ovaries actually look like. So she has a very individualised treatment. We have 4 nurse specialists within the department, and we have our quality manager, Bev, who's also here. Take a bow, Bev, wave at us. And she's continually auditing our quality and making sure that we're getting things right, which is very tactful. And we have Karen, who's not with us tonight, but who's our patient pathway coordinator and is often patients' first link into our service. Our 4 nurse specialists are, only one of them is full-time, the other 3 are part-time and make up 2.6 whole-time equivalents, but they certainly give us a lot more than 2.6 worth of people. The nurses you can see on the screen are 2 of our part-time nurses. They're Mel and Lucy, and they have a fantastic job. They see patients who are really distraught because I've just been through all the options and what fertility treatment is going to involve, and they have to calm patients down, explain the medication in more detail than I have, and then teach patients how to actually inject themselves and tell them that yes, they are going to be able to do it. Now, without our nurses, we'd be lost. Fertility medication does involve drugs and it involves injections. Patients are often needle phobic. I put 2 hormones up here. That's just to show that I'm not biased or promoting one versus another. Basically, in an IVF cycle, a lady, first of all, will switch her hormones off and we'll make her menopausal. So if she's desperate to have a child and we then make her have hot flushes and night sweats, she's not feeling too good. Then, when all her hormones are switched off, we'll then switch them on so that she'll have higher levels of hormones than she's ever had in her system before, and we wonder why they're on an emotional roller coaster. In a natural cycle, you're producing 1 egg. In an IVF cycle, I'm particularly greedy. I'm looking for somewhere between 10 and 15 because I'll always get a slightly lower fertilisation rate than 100%. And what I want to do is make as many good quality embryos as I possibly can to give her the highest chance of pregnancy that I possibly can. So, you take your drugs. During your drug taking, you're coming up every couple of days and we're scanning you, we're doing lots of blood tests. This is a picture of an ovary. It's got lots of black blobs and you can see one of them is measured. These are the follicles and that's where the mature eggs grow. Eggs are your largest cells in your body, but if you drew a fine pinpoint on a piece of paper, it's still a bit bigger than an egg, so you can't see it on the ultrasound. But those follicles there look like they should have eggs in. When they reach a certain maturity, we give a triggering injection, everything's injections, and then it's time for your egg collection. Egg collection occurs in theatre. It's a pretty straightforward procedure, and patients sometimes have no analgesia at all and sometimes opt to have a full general anaesthetic. The choice is entirely up to them. During an egg collection, the transvaginal ultrasound is performed. The needle passes through the vagina into the ovary and we take the eggs out that way. And all the eggs are placed into test tubes, hence the reason people talk about test tube babies. Once we've got those eggs into those test tubes, each test tube is labelled with the patient's name, unique hospital identifying number and date of birth. Is placed into an incubator where only that patient's eggs go, and the partner comes into the picture at this stage. He's been a support, but he's not really done a lot of this up until now. He is the transport, and we use 3 embryology labs here. One is at King's College, one is at the Bridge, which is London Bridge, and the other is Guy's and St Thomas's. And over the years we've gradually increased our linkage with all 3 hospitals because we think competition is healthy. You have embryology labs vying with each other to produce the best quality for your patients and also the best costs for your finance department. So that's quite a good point. When the chap gets to the embryology lab with his incubator, he hands it over to the embryologist. He's introduced into the little boy's room. He does his sample and the embryologist put the sperm with the egg. And then that's when the miracle happens and we aim to see fertilisation. Hopefully 18 hours later, you'll see something like this, which is a beautiful 2-cell embryo. And then 3 days later, we'd hope to see an 8-cell. You might look at that and think, wait a minute, she can't count. It looks like there's only 6. This is a 3D microscope, and so what we do is we scan through the embryo, but obviously I can't show you 3D photographs yet. And so that is an 8-cell embryo, even though it looks like 6. In natural cycles, the embryo actually implants in the uterus on day 5. So with modern culture mechanisms, we can now transfer embryos on day 5. These are called blastocysts. So it doesn't look as tidy, but this has got a lovely inner cell mass. It's just about to start hatching, and it's perfect for transfer. Transfer is relatively straightforward in view of all the other exciting things that have been going on. We look at the lady's cervix just like having a smear. We pass a very fine catheter, much thinner than a straw, into the uterus while scanning the lady's tummy, and the embryo is transferred in at that stage. Hopefully there will also be some nice spare quality embryos to freeze to use in the further cycle as well. It's quite a journey we've all of us who are in this room started off as a little embryo, somewhere ended up as a fetus, and then somebody kindly gave birth to us, otherwise we wouldn't be here right now. And this journey is fraught with all sorts of problems, not just for couples who are having IVF, but for all potential mothers and fathers to be. As I said, IVF is a relatively new process, and so is all forms of assisted conception. So we're constantly breaking the barriers and pushing the barriers under our legal guidance, of course. And latest developments that have happened here at St Helier, in 2010 we performed our first cryoprecipitation of oocytes. So in other words, we froze some eggs successfully. Basically, in the past, we've been able to freeze embryos relatively well. We've been able to freeze sperm relatively well. But if you were a lady and you didn't have a partner and you were about to undergo chemotherapy that was potentially going to make you infertile, it was just, well, sorry dear, that's one of those things, let's just get on and do your cancer treatment. So we've now pushed the boundaries and we started freezing here. We've had a lot of support and a lot of interest, not surprisingly, from our partners at the Marsden, and also particularly the breast unit at St George's. So we've had a lot more cancer patients coming through this year who we have frozen eggs for, and obviously if they've had a partner, we put them through treatment and frozen embryos. It's relatively early days, and what we're hoping is that they'll all get through their cancer treatment successfully, and potentially in 5 years' time we'll be able to help them to have a family. So that's something we're really keen to pursue. With regards to statistics, everybody likes to know statistics. Up till yesterday, we'd done 1,874 cycles of IVF here at St Helier. As of tomorrow morning, we'll have done another one. And if you want to look at the overall success rates, there's a stand in the non-such room which Beverly is managing, and you can see some of our rates there. The natural conception rate for a couple who've got no problems with infertility, who are having regular intercourse, is about 18% per cycle, i.e. per month. In an IVF cycle, overall conception rates, again, are very much related to the age of the woman, and sadly we haven't yet found a way of making women younger, but I'm working on it. And the overall rates are somewhere between about 20 and 40%. So statistically speaking, you could say that IVF was better than sex, but I know there are people who argue with that. The future, well, it's a bit of a brave new world. IVF has always been a little bit of a brave new world. We've got consultation, we've got commissioning, we've got BSBV. We may have a lovely new site. Whether it will look something like that, who knows anymore. What I would like to see for the future would certainly be an embryology lab on site, so our patients no longer have to travel, and I think that's potentially a realistic possibility. But what I'd just like to say is that whatever the future holds for us, the joy and the job satisfaction and being able to help couples to achieve their goals and having a family is absolutely fantastic, and there's no doubt in my mind that I'm part of the best speciality in the whole wide world. Thank you very much.